Okay, so when you picture a major burn injury, what comes to mind? Probably surgeons, right? Nurses working around the clock. But there's another specialist, one who's often working just behind the curtain, who is absolutely essential from the very first moment all the way through recovery. Today, we're pulling back that curtain on the incredible role of the anesthesiologist in burn care.
And to really get a sense of why this is so important, you have to look at the numbers. Every single year, just in the United States, 450,000 people need medical treatment for burn injuries. That's a huge number. This isn't some rare, isolated event. It's a massive, ongoing medical challenge. And that really gets to the heart of the matter, doesn't it? A severe burn isn't just a bad wound on your skin. No, it triggers a total, system-wide meltdown, a cascade of failures that can affect every single organ. So who's the one who steps in to manage that entire physiological storm? You might be surprised to hear it's the anesthesiologist. They're the experts in managing the entire human system under extreme stress. So, first things first, we have to wrap our heads around what a major burn actually does to a person. It's not just an injury on the outside. It's like a fire has been lit inside the entire body.
You know, it's fascinating. The body's reaction is like this crazy two-act play. In the first act, for about 24 to 48 hours, you have the ebb phase, or burn shock. Everything just shuts down. The heart pumps less, blood flow to vital organs plummets. But then, the body completely flips the script and enters the flow phase. Suddenly, it's in hyperdrive. The heart is pumping like crazy, and the body's metabolism is just tearing through protein and energy reserves. Managing these two completely opposite states is an incredible balancing act.
And believe me, the stakes here are astronomically high. There are 3 big risk factors: being over 60, having burns on more than 40% of your body, or having an inhalation injury. Now, with just one of those factors, the mortality rate is about 3%. Add a second one, it rockets up to 33%. And with all 3, a terrifying 90%. This just goes to show you, the anesthesiologist is managing a patient balanced on a knife's edge. All right, so let's focus on those first critical 48 hours. This is where the battle against burn shock is won or lost, and every single decision is absolutely pivotal for survival. So picture the ER. The anesthesiologist is running through the classic trauma checklist, the ABCs, airway, breathing, and circulation. But for a burn patient, each one of those is like a minefield with its own unique, urgent challenges. Airway is always, always number one. And this quote really says it all. See, with inhalation injuries and all the fluids being pumped into the patient, the airway can just swell completely shut, sometimes hours after the injury. So the anesthesiologist has this incredibly tough call to make. Do we intubate them now while we can? Or do we wait and risk an impossible life-threatening situation later? Okay, so once the airway is secure, the next enemy is burn shock. And it is just as scary as it sounds. All the body's blood vessels basically become leaky faucets, pouring plasma fluid out of the bloodstream and into the tissues. This makes the blood volume plummet, and it starts starving the organs of oxygen. It's a race against time to counteract this. So you might be wondering, how much fluid are we talking about here? Well, it is a staggering amount. Anesthesiologists use formulas like the famous Parkland formula as a starting point. For an average person with a 60% burn, that could mean almost 17 liters of fluid in just 24 hours. But here's the thing, that's just a guide. The real art is in fine-tuning that flow, minute by minute, based on how the patient is responding, all to keep the organs working without flooding the entire system. So, if the patient makes it through that initial shock phase, they're often headed straight for the operating room. And this is where the anesthesiologist's job gets cranked up to a whole new level of difficulty. And get this, just to paint a picture for you, the operating room itself is often heated to between 80 and 100 degrees Fahrenheit. Yeah, tropical temperatures. Why? Because without their skin, the patient's internal thermostat is just broken. Hypothermia is a huge risk that can stop the heart. So the whole team has to work in that intense heat just to keep the patient safe. And that's just the temperature. At the same time, the anesthesiologist is a master juggler. They're managing huge amounts of blood loss, trying to find a tiny usable vein in swollen, damaged tissue for an IV, all while dealing with lungs that might be damaged from smoke and trying to predict how the body will react to drugs it's never seen before. It's chaos. Okay, here's a perfect and frankly terrifying example of how different their bodies are. There's a common muscle relaxant called succinylcholine that's used safely every single day.
But if you give that same drug to a burn patient more than 48 hours after their injury, it can be fatal. It can cause a massive sudden release of potassium that instantly stops the heart. Understanding this isn't just academic, it's what separates life from death on the operating table. So, getting through surgery is a massive victory. But the anesthesiologist's job is far from over, because now begins the real marathon, managing burn pain, it's considered one of the worst kinds of pain a human can experience.
And you can't just throw painkillers at it. You have to understand it. First, there's the constant grinding background pain that's just always there. Then, you have the sharp, blinding procedural pain that comes with every dressing change or physical therapy session. And on top of all that, you get these sudden spikes of breakthrough pain that come out of nowhere. You have to have a plan for all three, all the time.
Now, the traditional weapon against this pain is, of course, opioids. But here's the catch, the cruel irony. Burn patients build up a tolerance to opioids incredibly fast, so they need higher and higher doses. And they can lead to this bizarre trap called opioid-induced hyperalgesia, where the very medicine that's supposed to help actually starts making them more sensitive to pain. So because of that whole opioid trap, the modern approach has to be way smarter. It's got to be multimodal. This means you're not just relying on one thing. You're combining smaller doses of opioids with other drugs like ketamine, you're using regional anesthesia, and you're even bringing in things like virtual reality to attack the pain from every possible angle.
And one of the real game changers in this toolkit is regional anesthesia. I'm talking about things like nerve blocks or epidurals. Instead of drugging the whole body and brain, you just turn off the pain signals from one specific area. It provides incredible relief, especially during those painful procedures, and dramatically cuts down on the need for all those opioids.
So you see, this isn't a job that happens in just one room or on just one day. The anesthesiologist is on this journey with the patient, and their role is constantly changing right alongside them. I mean, look at this journey. At the very beginning, in the ER, they are the resuscitation expert. Then, in the OR, they're the perioperative physician. They follow the patient to the ICU, where they act as a critical care specialist, and for months after, during the long, hard recovery, they become the pain management specialist. It's an incredible spectrum of expertise. So at the end of the day, this job is so much bigger than just putting people to sleep. It's really about being the systems engineer for a human body that's in absolute crisis, managing everything from their heart and lungs to their drug responses and their complex relationship with pain. And what are they all working towards? The goal is, well, it's both simple and unbelievably profound. This quote puts it perfectly. The ultimate challenge is to strive for no deaths, no scars, and no pain.
And that really leaves us with this final big question. We've gotten so incredibly good at that first part and making sure people survive these horrific injuries. But the next frontier, the challenge anesthesiologists are tackling right now, is so much deeper. It's not just about survival anymore. It's about how we truly restore a life that is finally truly free from pain.